begin with Deborah Wickens. Deborah has worked in tissue viability for the past 14 years, both in the community and acute settings. Deborah is currently the lead nurse for harm-free care at Barking, Havering and Redbridge University Hospitals NHS Trust. She has a special interest in pressure ulcer prevention and was proud to be part of the winning team at the Nursing Times Awards in 2019 for the Innovation in Chronic Wound Care Award. This award was given to acknowledge the team's work in patient and care education.
My background is tissue viability for quite some time. I'm really passionate about pressure ulcers, both prevention and the effect that they have on our patients. And what I'd like to talk to you about today is a particular case where I think the importance of thinking widely about your patient's needs when you come to the selection of the right surface was really important for this gentleman. So just to give you a little bit of background, we had a 51-year-old gentleman admitted to our acute hospital. He had a history of cardiac failure. He'd had squamous cell carcinoma to the oropharynx, and he was a smoker with a high previous alcohol intake. So he presented to us back in November of 2021 to the trust with a perforated duodenal ulcer, and his recovery from that proved to be quite complex. So he was back and forward to theatre for multiple relooks and was eventually referred to our service in December of 2021. So when we first saw this gentleman, it was actually to support a high output fistula, which had been an extensive area of surrounding ulceration. It was really a very active fistula, and that made it really difficult to manage. Despite high involvement from across the MDT, the seal on that often failed as the patient moved. And I think that made the people caring for him and him really nervous about any movement and how it would affect that seal, because he was then soaked in sort of mucoid type fluid. We did do some work trying to isolate the fistula, but that proved impossible. We also tried him on some negative pressure wound therapy. We kept that on really low settings and worked with our surgeons for a plan on that. But again, bile pulled through via the fistula, so he continued to be managed with the large ostomy bag products. And that in turn infected his pressure ulcer risk. So that frequent repositioning was causing the stoma bag to leak. So we knew that this gentleman was not doing well nutritionally. He was really high risk. We needed to move him quite a lot. But as we did move him, the products of the fistula were leaking onto his skin. And obviously they're affecting the acid mantle of the skin and causing erosion and raising that pressure ulcer risk. Because he was in pain, he frequently declined repositioning. This was a young man with capacity. He was quite clear on what he did and didn't want. We spent a lot of time talking with him about what the risks were and what we wanted to do to support him. He was exhausted as well. He wasn't sleeping because of his pain, and as a result of that, he was not engaging with therapists and was failing to meet a lot of his rehab goals. He remained on a tracheostomy with a really slow wean, had almost no sitting balance, so those will further complicate not just his pressure ulcer risk, but his overall risk in terms of reaching his goals for rehab and recovery. And despite the parenteral feed, we had this really high output fistula, and that really challenged his protein needs in terms of skin integrity and then wound healing. And as we said, this very slow wean tracheostomy. And another thing is that when he was turned, it would very often plug off the tracheostomy. So that was incredibly scary for him. And it was yet another reason why he found being moved about quite so difficult. And we got a new TVN referral a few weeks later, which things had really turned in the wrong direction. So at that point, as you can see from the diagrams we've got here, he had an unstageable pressure ulcer to his occipital. There was an ulcer on the thoracic spine, and there was also initially multiple wounds that we could see on the sacrum, although we were aware that they were very likely just the surface manifestation of one larger wound underneath. He was now in more pain. He was frightened to put his head back on the pillow, for instance, I remember, and really distressed by what was going on. He was sleeping even less than he'd ever slept before, and his engagement with healthcare professionals was deteriorating as a result of all of these things. And you can see there that we've got a little summary of the wounds at the time that we made some changes in his plan. So we had this 9 centimetre by 9 centimetre wound on his sacrum. On the occipital, we had a 2 centimetre wound, and we had that linear wound on the spine. So we tried some of the standard things that would be on most people's pathways to start with. So we put him on an alternating therapy dynamic mattress. He found that he did not like the mattress turns. He was really very distressed by the idea of people turning him. And I think that almost played in with the staff, who were anxious to protect the peri-wound area and just anxious about distressing him. And the wounds were still extending, so we weren't achieving any of our goals at that point. So we then turned to a low air loss mattress that we have within the trust with turn assist, but we continued to have challenges with pain and repositioning, and the wounds were still extending. So even then we weren't meeting our therapy goals for this patient. And at that point, to my shame that I didn't think of it sooner, but at that point my mind went back to a conference that I'd been at a number of years ago, where I'd seen the dolphin, and I'd seen some of the beds that Medstrom produce as well. And I made a call to Medstrom to say, well, is this a patient that you think would benefit from this therapy? And one of the things I'd really like to share with you is how important the support that we had from Medstrom was in making the right decisions for this patient. So we decided that we would like to explore using a fluid immersion therapy system for this patient, firstly because he was really poorly tolerating even the interface pressures from our dynamic and low air loss systems, and secondly because we knew that we could use a more sophisticated turn assist system with the bed that we had brought in for him as well. So really we were trying to almost sort of immerse him in a comfortable environment, and as well as protecting his wounds and hoping to stimulate healing, our other goals were around actually this gentleman's quality of life. And I think hopefully as we go through, you'll see that the impacts that we managed to have. So the first thing that we always talk about in terms of outcomes is what happened to the wounds. And I think you can see here after 9 and 12 weeks how we had those two of the wounds healed, and an 80% reduction in the wound area in the large wound on his sacrum. So that's what we will often measure when we talk about what a therapy has done for a patient. But as nurses, we're used to thinking more widely as well. And actually the things that really struck me are that he had rest and sleep. There was a reduction in his reported pain, and he started to engage with therapists. So by managing his wound and managing his pain using a surface, we were able to move other goals forward. And I will always remember he was really anxious because he'd been through so much about going on to the dolphin bed and dolphin mattress and the Medstrom bed. And we had to work really hard with him to sort of sell the benefits of it. But when we went back the next day, he was asleep in bed, and it's the first time I'd ever seen him asleep. And I think that for him was the thing that he was most grateful for that rest, because we all know how difficult it is to think, to act when we are exhausted. So this gentleman went on to be moved to another hospital for further surgical intervention, and very sadly he passed away in a hospice sometime later. But we followed up his therapy as he went around to ensure that he still had access to the right equipment to keep him comfortable. And actually his wounds were doing incredibly well. They were healed or almost healed, all of them, at the time that he sadly passed away. So there was a lot of learning for us to take from this particular case. And we sat down as a team and talked about how what we'd learnt would influence what we did for patients who we met in the future. And so following this case, we drew up a pathway so that we would prompt ourselves to think in a more proactive way about something like the dolphin, because the big regret that I took away was that I hadn't thought about it sooner, because I could have made him comfortable sooner. So our pathway sits with the tissue viability nurses within the hospital, but there are groups of patients that we will automatically consider now. So category 4 pressure ulcers and DTIs and multiple pressure ulcers we will consider. Extreme low weight patients with nutritional challenges, patients with contractions who can't reposition themselves because of the degree of their contractures. And I'm sure we've all perhaps cared for patients with extreme contractures where you can really only tilt them at 90 degrees. And the other thing that we've looked at is bilateral amputees. And that was another case that I'm not presenting today, but we did have a patient who was a bilateral amputee, and it was very hard to maintain the right position for him in the bed, and there were significant shearing forces. And actually, so we now routinely consider it and request referrals for bilateral amputees who come into our hospital, and have seen actually some quite impressive outcomes in that group of patients. And we also look at hospital-acquired pressure ulcers with the potential to deteriorate. So we will see all of those patients and make a recommendation for dolphin therapy if we think that's the right thing. And we are now regularly using them and regularly seeing really positive outcomes. So thank you so much for your time and listening to me today. And at the end of the session, I look forward to answering any questions you might have. Thank you.